you, Professor. Thank you so much for such a beautiful series of cases. This looks like we are watching the future in the past from your cases. So much to learn. Now
Thank you.
we are going to move to Dr. Yi Yang for his work in lymphedema. He's expert in doing the power-assisted liposuction techniques in lymphedema advanced cases. So the floor is yours, Yi Yang. You can share your presentation. Thank you.
Thank you, Dr. Benson, for moderating this. Thank you, Koshima-sensei, for teaching us the future. Okay, I'm going to share a topic with power-assisted liposuction vibration liposuction combined with LVA surgery in stages for severe limb lymphedema. I'm Dr. Yang from the First State Affiliated Hospital of Sun Yat-sen University. It's my great honor to join this club. Thank you. I'm going to show you a picture. This is Dr. Kushima. I visited him in Japan last year, and this is my friend, Dr. Mansun. Thank you for this. I'm going to introduce my hospital a little bit. Our hospital is located in the South China, Guangzhou, very near Hong Kong and Macau. And this is my city. Our hospital now have 5 sections, and our hospital is named after the father of China, Dr. Sun Yat-sen. Our hospital ranked top 10 in China. So microsurgical treatment for lymphedema in our department has a very long history. Back in 1979, we performed the first LVA in China. And 10 years ago, we performed the first VLNT in China. For now, we have a lot of devices. We have ZSK19, Mitaka, and a 3D scan, and a lot of lymphatic effect suction machine, and a lot of ICG machine. Our team have 14 departments, and this is our team, our department. So today's presentation will cover following key topics: background, case reports, and a summary. I hope this presentation will provide valuable insights to improving the management of severe lymphedema. As we know, lymphedema is chronic progressive disorder that can be classified based on the International Society of Lymphology staging system, which is stage 0, stage 1, stage 2, and stage 3. Especially in stage 2 and stage 3 lymphedema, the subcutaneous fat is abnormal, proliferative, and rubber-like, making treatment very difficult. In this stage 3 lymphedema, I don't think only LVA will work on these patients. So what is your treatment choice? The pathologic changes in late stages lymphedema is extensive fat deposition, fibrosis, and the subcutaneous adipose tissue lymphedema limbs is abnormal, proliferative, dense-like, and contains clean septa, making liposuction significantly more difficult than typical procedures, and there is great damage to peripheral blood vessels and increased bleeding. The ISL guidelines recommended a comprehensive management approach combining conservative therapy and a surgical intervention, and the liposuction is one of the most important tools. Liposuction is considered an effective treatment method for advanced persistent primary or secondary lymphedema. However, traditional liposuction methods have limited effectiveness in patients like this. Okay, so the traditional surgical approach Options for lymphedema includes like the C.R.A.Z.Y procedure, which is established in 1912. It is effective for extremely elephantiasis, but has high bleeding risk and a long recovery time and various complications. The conventional liposuction, which is limited, has limited fat removal efficiency and high complication rates, especially in fibrotic tissue. So, to prove these outcomes, we propose a two-stage approach. The stage one is like power assisted liposuction, vibration liposuction for volume reduction. And in stage two, we perform LVA surgery for lymphatic venous anastomosis and physiological reconstruction. This combined approach achieves better function and aesthetic outcomes. The PAL liposuction system includes built-in air compression pump and power a 360 oscillating cannula and then 600 cycles per minute of oscillating with 8 mm forward or backward and a 6 mm left or right movement, ensuring efficient fat removal, smooth tissue contouring, and minimal vascular and nerve damage. This reduces surgical time and reduce post-surgical seroma and fluid retention. This method referred as violin or like erhu, a traditional Chinese instrument technique due to its precise and rhythmic movements enhancing surgical efficiency. Compared to traditional suction-assisted liposuction, PAL liposuction offers several advantages. First is like high efficiency, lower damage because of the 600 cycling per minute vibration, preserve blood vessels and nerves, reducing trauma. And the second one is like increased safety, spiral tissue disruption technique minimize damage and prevents vessel rupture. And the third one is like fast fat removal, particularly effective for fibrotic tissue and allowing for greater volume reduction in less time. These advantages make PAL vibration liposuction an excellent choice for treating severe lymphedema. The mechanism of PAL vibrations liposuction is by using high energy vibration liposuction machine at zero point 0.8 to zero point 0.9 atmosphere, beneficial for removing subcutaneous pathologic adipose tissue, stagnant lymph fluid. The ideal candidates for PL AL liposuction includes stage 2 or stage 3 patients where conservative treatment has failed, and primary lymphedema causes with predominantly fat tissue thickening and progressive symptoms that significantly impair function. The contraindication include mild lymphedema such as like stage 1 or stage 0, which and patient under 16 years old, which patient may be very benefit from the lymph node transfer, and blood clotting disorders or deep venous thrombosis, and the active infection in the affected limb, and poor overall health or inability to comply with post-surgical compression therapy. PAL liposuction follows those key surgical principles. The first one is like tissue fluid infusion, sweating fluid composition of normosanin and lidocaine and epinephrine. The incision design, small 0.5 centimeter incisions along the inner and outer side or calf. The direction of suction should be as parallel as possible to the longitudinal axis of the lower limb. Post-operative management should be like placement of 2 to 4 drainage tubes, and the second one is elastic bandage compression to reduce complication. The incision design is like above the knee on the inner or outer side of the thigh, below and the knee on the inner and outer side of the calf, and the incision should not be very large. 0.5 centimeter small incision could be enough. Align along the limb's longitudinal axis. For the sweating fluid, infuse until the skin shows slight of orange peel changes. In our department, we use like 500 milliliter normal saline with lidocaine and epinephrine. For the details of the lymphedema liposuction surgical method, you can take a picture of this slide, such as using a peristaltic pump or to perfuse sweating fluid to subcutaneous fat accumulation areas requiring suction. 2. Elastic bandage compression, dressing the limb. After the liposuction, you can do flying squirrel style. You need to remove this abundant skin, like this in this patient. Okay, I'm going to show some cases in the, so this is the upper limb case. This patient actually had lymph node transfer in other hospital, but it's failed. And she had LVA in other hospital, but it doesn't work. So in our department, we performed the liposuction first. And this is a primary 22-year female, has lymphedema. When she came to our hospital, you can see this is a very severe one, very late stage. So we performed the liposuction in 2 stages. The first one is like in the lower calf, and the second one is in the thigh. So we have, after the liposuction, you can see these beautiful results. So based on the Cleveland Clinic experience, I have been staying in Cleveland Clinic for a while. So Dr. Wei-Fan Chen, he proposed a hybrid technique after the first stage of liposuction, like 1 year or 2. So the patient received LVA. So in this patient, we have very beautiful LVA. Like before the surgery, we have high frequency ultrasound and ICG to locate those lymphatic vessels. So under the surgery, we can have very beautiful lymphatic vessels and blood vessels. So all those are very beautiful anastomosis. So in conclusion, the key takeaway from our study are like strict adherence to surgical indications and accurate pre-operative assessment. Lower limb surgeries are more challenging than upper limbs. Women show faster liposuction speed when men have higher intraoperative bleeding rates, and the infection patients have increased bleeding and higher surgical difficulty. When using the sweating fluid and a tourniquet technique helps reducing bleed, and the post-operatively compression therapy is very important for those patients. Welcome to join us. We have all kinds of surgeries for lymphedema, such as lymph node transfer, LV, and liposuction. Thank you for your attention. Appreciate your time and look forward to any questions of discuss. Please feel free to contact me for further inquiries. Thank you.
Thank you, Yang, for a nice presentation and your beautiful work. Uh, I would like to invite questions from the audience. Anyone who would like to ask any question, they can leave it in the chat box. Along with they can, if they want to talk, they can raise hand. Thank you. I'll start with the question by myself. My first question is from Professor Kushima. Professor, how do you plan the perforator flaps? Do you always use the CT angio to locate the perforator?
Oh I always use preoperative ultrasound echo, color Doppler, and detect perforator. But probably this technique is very useful. I used to use liposuction, not this kind of sophisticated, simple liposuction. So post-operative, problem was a post-operative contracture. So fibrosis occurs with the liposuck area, and some patients show the contracture, subcutaneous contracture, and I always use secondary liposuction. The first I use multi-site LVA because primary liposuck damage cause fibrosis. So dissection of lymphatics little bit difficult. Fibrosis disturb liposuction. So that's why I always use, and later, because first stage I establish multi-site LBS, so some can show the dramatic improvement. So no need to do the liposuck, even a stage 2 or 3. Some can show the dramatic improvement. So also I only use liposuction for the indication of my liposuck is case after LVA, accumulation of lymphatic fluid disappear, become a soft, hard leg, become a soft leg. This is absolute indication. But still, lymphatic fluid are still accumulated. Those cases, even if liposuck perform, the result is not so good. So that's why indication of liposuction is very, very strict. Only the case who has soft change is absolute indication. So this is my personal also I the professional liposuck guy in Sweden. I forget his name. Probably you remember his name. But anyway,
Dr. Boson.
He always saying the same thing as I said. Only the indication of liposuck is such a case. Yeah, is some case had a very hard leg. Those cases also nowadays we can measure the water volume by impedance technique. So that's why we can indicate objective indication is now possible. So, but you are doing the first liposuction and the secondary lympho, but probably you are doing a liposuction LVA for the not liposuction area. So probably it's okay. Probably it's possible. And my question is, how about the fibrosis in the secondary LVA? Also bleeding. You are doing extensive liposuctions. So some cases show post-operative bleeding. Also a long time follow-up, and also the indication such a case, hard case, accumulated water case. You're also doing the liposuction? Yeah. Yeah, these are my questions. Please, teach me your experience.
No. Dr. Kashima Sensei, you are my mentor, so I have no rights to teach you. I stayed in Japan, in Hiroshima. You teach me how to do the LVA. So I just want to share my experience, a little bit of my experience. We performed like the liposuction in stage 1, like 1 year. After, then you can perform LVA. During that time, yeah, it's a little bit difficult to do the LVA. There is a lot of fibrosis under the skin, but when you find the lymphatic vessels, it's going to be very nice. It's going to be very nice. It's very big, and the lymph fluid coming out from the lymphatic vessel is very good. So after like 1 year or two, you can perform. It is possible for you to perform the LVA. It is possible. So yeah, but it's a little bit difficult. There's a lot of fibrosis under the skin.
How about the long-term follow-up? You
Yeah,
follow?
the long-term follow-up. Yeah, I don't have very long-term follow-up after this, but based on Dr. Wei Fan Chen from Cleveland Clinic, I think you know him. He had very good results. Actually, he has like several patients that after this hybrid technique, there will be no tourniquet. They don't need to like bandage. They don't need garment. Several of his patients. But I will report my outcome in the future. Thank you, Sensei.
So you need not to use the post-operative compression?
Yeah, there will be yeah, some of the patients of the Dr. Wei Fan Chen, maybe like several patients a year, they will not need the compression treatment.
Okay. Okay, yeah. This technique is a completely new technique. Yeah, not a standard liposuction, so special vibration liposuction. I had this technique maybe 10 years ago in Bocardo, or Italian group, Campishi group. I use this technique, but I don't know now. Now they are doing same technique or not. But in Japan, I never heard. But probably aesthetic surgeons are now probably doing using this vibration liposuction. Vibration equipment is probably not yet admitted in Japanese government. So probably at this stage, it's probably little difficult in standard hospital in Japan.
Yeah, I know that most of maybe like almost all the doctors are learn the LVA from you. Last I think like 2 months before I meet Aki and some other doctors from Japan in Shenzhen. So I think they are all your students.
Are using this equipment vibration liposuction?
Not a lot
No.
of doctors using this technique in Japan.
Government not yet allow, probably. That's the reason. Okay,
All right.
thank you. The other one may have a question, many questions.
Uh, Thank you, Professor, for the question, for the nice question. Now we have Dr. Safdar from Pakistan. He has a question. Safdar, you can unmute yourself.
Thank
Thank
you,
you.
Mansoor. Hello, Professor Kushima, and hello, Yiyang. How are you?
Hello.
You can hear me, right?
Yeah,
So, Yiyang,
nice to meet
you
you
must be
again.
remembering. Yeah, nice to meet you. We met in
We met
Peshawar, and
in
now,
Peshawar.
yeah, yeah. How can I forget that? So, my question starts from you, Dr. Yi Yang. So, since the lymphedema has two main procedures, one is reductive and one is physiologic. The physiologic is LVA and lymph node. So, what do you think the liposuction is only the reductive procedure, or it helps in recirculation of the lymph also?
Actually, after we perform the liposuction, like 3 months late, we perform ICG to those patients. Before the liposuction surgery, we do not see very good lymphatic vessels with the ICG, but like 3 months is late, we can see some of the lymphatic vessels, very good one. So I think after the liposuction, they might be like lymphatic vessels regeneration.
Give me explanation. Right, right. So good.
You
So
confirm
another.
ICG? You confirmed by ICG study?
Yeah, I confirmed with
Oh,
the ICG.
okay, okay.
So my next question will be, if you are doing it along with LVA, sometimes you do it with LVA. Professor F. Chen, you also named him. He also does with the liposuction along with LVA also. So do you do the LVA first or the liposuction first? And then-
Liposuction first. But it's for the late stage lymphedema, liposuction first. But for the
Okay,
early ones, LVA first. Sometimes like lymph node transfer.
okay, thank
Because
you. So
I visited Professor Cranny Baker, and she's the inventor of this kind of technique. She is very fond of this lymphatic lymph node transfer.
okay, so my another question is, how is your power assisted this liposuction different from any liposuction of a fatty leg? Is there any difference in the technique for the
It's
lymphedema?
more proficiency to remove those fibrosis tissue and less bleeding.
Okay, okay. So it's the procedure wise, it's almost the same. The way anyone does for a fatty leg, or if someone does it for lymphedema, the procedure is not something different for the leg, right?
What?
The technique of liposuction of a leg, it would be the same, right?
Yeah.
Yeah. Okay. My last question is, how do you actually choose your patient? The professor has asked you the same question, but if the patient comes to you, how would you choose a patient for the liposuction? Not all the patients will suit for liposuction, right?
Yeah, I mean, for the late stage patients, like you mean, like you can see
Mm,
that the extremity is very large, and
mm,
it's like a fibrosis predominant. It's
mm,
not fluid dominant. Actually,
mm.
I will choose these patients to receive like liposuction.
Okay, great. So, do you do also the second stage or third stage later on, the liposuction?
Uh, for the upper limb, I prefer in one stage, the whole limb in one stage. But to do a very good liposuction in those kind of
Mm,
patients with very severe fibrosis is very difficult. It's very exhausting. So
mm,
for the
mm.
lower limb, I do it in two stages. The first one is like for the calf, and the 3 months is late for the thigh.
Okay, great. So
If
when I
you
asked
you
you,
want to do a very good liposuction
mm,
for the lower limb,
mm,
you need at least 3 hours to do it in perfect.
mm.
It's
So
very
okay.
exhausting.
So on a lighter note, I would just want to ask you, once I was doing liposuction of a patient, not for the lymphedema, of course, and then when I went to a microsurgical procedures, my hands were shaking, just like
Yeah.
I had to. So how do you actually do liposuction first and then LV in the patient? for the same stage. So do you don't
No, you
face this
cannot do
problem
it in the same stage.
in the same stage, not in the same stage, of course.
Yeah,
So
not in the same stage.
thank you, Yuyang. Thank you so much. My last question from Professor Koshima. Thank you, Professor Koshima, for a wonderful presentation. As Dr. Mansoor said, it was just like back to the future kind of a thing. So my question is, these medial plantar flaps are very good for heels and everything, but they are also very good flaps for hand, the fingers that you showed. Because they are glabrous, the skin is glabrous and it is sensate. These two qualities made it make it more perfect. But we also often see that this is slightly bulkier than the other thin flap options if we have. So do you always need to, or sometimes you have to go back and thin those flap? And if you do, then how do you take care of the sensory nerve? Vascularity is not a problem, I think, then how do you actually preserve the sensory nerve, which is very important for those flaps?
Yeah, this is a very important point. So singing is a little bit difficult because nerve fiber is including the fatty tissue. So that's why if you preserve fatty tissue, nerve fiber, singing is a little bit difficult. So secondary departing are necessary. Primary surgery, fatty tissue is better to preserve. Later, this could be shrink, become flat. So finally, if necessary, departing, secondary departing is better than the primary departing. Adipose tissue sometimes, so all of my free tissue transfers nowadays, I always preserve bulky flap, bulky adipose tissue. This bulky adipose is essential for aesthetic secondary correction of surrounding depressed area. So post-operative atrophy always occur, especially exposing area, especially face. So long-time follow-up, I always have shame because of the primary departing. We cannot do anything. So always preserve. So this is a banking concept. Always preserve fatty tissue. So finger and plantar region, we should preserve the heavy amount of soft tissue. Also head and neck, probably in future, thin flap would be disappear. Long-term follow-up, we always regret the primary departing. So this is my concept. So thank you. Very important question.
Thank you, sir. Thank you. So if you need to do thinning in the second stage, how do you take care of the nerve? Do you identify the nerve then?
Yeah, microscopic.
Microscopic.
Yeah,
Okay.
but usually fingertip, finger pulp, reconstruction. We need not nerve suture. Completely normal sensory recovery.
Agree.
But plantar region, we should preserve the nerve.
Yeah. Thank you. Thank you so much.
Yeah, welcome. Very nice.
Sir,
Always. You
Thank
propose a nice question.
thank you, sir, for nice questions.
Because
Now
you
we
have
have
a many case experience. Yeah. Okay.
thank you, sir, for the
Yeah,
nice
welcome.
questions. Now we have Anil Agu, who has a question for Dr. Yangi. Anil, you can unmute yourself.
Thank you very much for the wonderful presentations. I thoroughly enjoyed both presentations. I just have my questions for Dr. Yang. I have 3 questions for him. My first question is, you said that in mild cases of lymphedema, that you do LVA first. Have you, in that circumstance, secondly done any liposuction after? In any circumstance, have you? done a liposuction after doing the LVA?
In the minor cases, I wouldn't choose liposuction. We have, like, we can perform LVA repeatedly, like in Sensei did in Japan, and we have lymph node transfer. So, and we have bandage, garment. So, if this patient condition can be controlled, not too progressive, so maybe the patient do not need any liposuction.
Okay. You also mentioned that you do for grotesque cases, the cases maybe stages 2 or 3, that you do liposuction first before LVA. How easy is that? Because after a liposuction, you expect a lot of fibrosis, and the dissection becomes very difficult. How easy do you think it is from your
Yeah,
experience?
Sensei just asked about this question. It's not difficult to find these lymphatics. So what you needed to do is you have a team, especially ultrasound, using the high frequency ultrasound to locate the lymphatic vessels first, and with the ICG to locate the lymphatic vessels first, and with and after during the surgery, you can find very good lymphatic vessels. So you don't have to worry about the damage of these lymphatic vessels. It will be very good lymphatic vessels, but it's difficult. It because of the fibrosis, it is difficult.
Okay, have you ever tried to do a liposuction first in mild cases? Have you ever tried it? Is it something that you have given a thought?
No, I haven't tried
doing
that.
a liposuction first? Yeah.
No, I haven't
What will
tried.
happen? What will happen if that is done?
What?
In my case, what will happen? What do you think will happen if, in my cases, you do a liposuction?
I don't know what it will happen because, liposuction in this case is kind of like very painful for those patients. So to reduce the painful, so I haven't do this kind of surgery. But basically, I think it will happen as the severe ones, as the later stage ones. It will to promote the lymphatic vessels regeneration. I think it will be the same thing.
Okay. Okay. So there are no consequences if somebody does a liposuction in mild. Has anybody tried it? Do you have any literature or anybody who has tried liposuction in mild cases? Is there any literature? Somebody who has tried it, and what was the outcome?
Maybe you can Google or PubMed Dr. Bolson. He's one of the pioneer of the liposuction, and maybe you can search Weifan Chen. He has done a lot of works on liposuction about this.
Okay. Is there any way we can have a contact with him or something so we can
You can
verify
email
that?
him. You can email him.
What's the name?
Weifan Chen.
Name.
Weifan
Okay.
Chen.
Okay. Thank you.
Not a problem.
Thank you, Anil, for the nice question. Professor Kushima, do you want to comment on the liposuction in the early stages?
Oh, early stage, I should not do. Yeah, do the LVA. Yeah, absolute indication of LVA. So in the early stage, many cases show the complete recovery, so no need to do the such a technique, liposuctions.
It's painful.
Yeah, painful also. Also, not so much adipose proliferation. only water. So LVA works very well. Also, early stage lymph channel are still working, contracting. Smooth muscle cells are intact in early stage. But stage 3 and 4, smooth muscle cells disappear. So probably with this vibration liposuction, probably he said function of smooth muscle cell, a recovery occur with with the previous vibration liposuction. If it is true, probably a complete recovery maybe occurs with even stage 3 and 4. So this is the may become a big improvement. Revolution may occur if regeneration of function of lymph channel change, recover with liposuction. So many patients will be salvaged. We should try, continue this technique. Okay, very
Thank you,
nice.
Professor, for the comments.
Yeah.
Now, I have a question, Professor. When we talk about the liposuction, we should consider the complications as well. Liposuction can lead to septicemia, and we can lose the patient as well. There can be the most dangerous complication. So, how do you make sure it is both for the Yang and Dr. Kushima? How do you make sure that we don't lead into complication preoperative planning?
You mean prevention of complication of
Yes,
liposuction?
yes, Professor.
Yeah. I have not so serious problem. It's sometimes other doctor cause massive bleeding, so blood transfusion now. Yeah, so volume of liposuction should be prevent less than 1 liter. So never try massive liposuctions, 2 liter or 3 liter. Sometimes needs blood transfusion. So blood transfusion is too invasive for this lymphoedema. So that's why, also if we do low abdominal liposuction, some aesthetic doctors injure the intestine and post-pamperitoneitis occur, and this aesthetic unit has no a bed stay after surgery, so that's why patients go back to home. And this caused 20 years ago in Tokyo area, aesthetic liposuction injured perforation of intestine. And 3 days after surgery, patient died with dehydration in her home. So police ask me, this low caliber. Police asked the caliber in the university, Tokyo University Hospital. So specialist of dead body inspector asked me, came to me, and he asked me, why patient die? Because this perforation, several perforations are completely closed with the omentum, and inflammation, intra-abdominal inflammation, not so severe. But anyway, she died. This was not caused by the paralytic temporary ileus, paralysis intestine. cause vomiting, and the patient cannot go to the emergency hospital because this is aesthetic liposuction. So that's why patients stay at home and cannot eat and drink. So that's why dehydration caused her death. So aesthetic doctor has innocent, no punishment, because this is the patient responsibility. So this accent teach me many things, and many times I'm presenting this comment in the on the liposuction. This is a serious problem. So that's why liposuction sometimes injure the population of intestine. In that case, short time, temporary intestinal paralysis occurs. So that's why admission is always necessary after liposuction. So this is the most important point to prevent a death after the liposuction. Even if intestinal population occurs, the patient never die with fluid injection, transfusion. So probably this is the most important point. Prevent lawsuit. Also, blood, bleeding. Bleeding also, always we must prepare blood transfusions. So this is a serious problem after liposuction. Okay. Also another problem is sudden death occurs after liposuction for the patient. Edema, inflammatory lymphedema. This is very, very dangerous. If we do liposuction, bacteria spread whole body. A septic shock occurs. 1 month or 2 months after patient discharge, sudden death occurs. I have the one case of such a sudden death, a very infective case, and elephantiasis. So those cases has bacteria, cluster of bacteria between the adipose tissue. So if we do liposuction for this patient, temporary improvement with the antibiotics occur, but several maybe 1 month or 2 months later, spreading of the bacteria also occurs when they come back to home, and nighttime sudden death probably maybe occurs. So be careful. Never liposuction for inflammatory case. Also, elephantiasis, very severe case. We should not do. This is my comment for young generation.
Thank you.
Okay,
Thank you,
welcome.
Professor, for the nice comments. Now we have Sachin. Sachin, do you have any questions?
Yeah, Sensei actually answered all the questions about liposuction, but yet, Yang, it was a very good presentation. I I would just ask, what do you do an MRI for the patient before you go for liposuction? Do you do any investigation?
Mm, actually, I'm doing a research before and after the liposuction. I want to see
Hmm.
how the perforator changes,
Okay.
because a lot of doctors worry about it's like a degloving injury.
Mhm.
Yeah, because we have in our country, we have lymphedema, all stage, ISL stage 3, and elephantiasis. So I really don't know how to proceed with such cases. As Sensei very clearly mentioned, he always tells about this bacteria as golden bacteria.
Learning,
Sensei, you he termed this as golden bacteria, which looks like a gold under the microscopes. So I'm always worried if I do liposuction and this patient undergoes septic shock, it will be very dangerous for our patient. So I avoid liposuction. Even if I do, as I have seen Sensei doing on the lateral aspect where the lymphatic channels are less. So medially, I do LVAs. On the lateral aspect of the thigh and leg, I do small liposuction, maybe of only 200, 300 ml to be on safer side. And if I require, I do excision, the small excisions of different parts. So, but very good to know. I think your cases are mostly post-cancer cases, not infection related. So I think liposuction is very well have a role in the cases, and in future we'll see it much more. About Sensei's talk, Sensei, I just mentioned to you to talk about a medial plantar flap, but it is like going through so many flaps by one single flap you have shown today. And very aptly, Mansoor said today that it is going in the future by going to the past. We never knew so many things are there in the middle plantar flap as today you have demonstrated, shown us. Thank you very much, Sensei. Much more to learn
Yeah,
from you. Thank you.
yeah, welcome,
These are my
welcome.
comments.
Okay, thank you.
Thank you,
Thank
Sachin,
you.
for the nice comments and the questions. I have last question from Professor Kushima. These medial plantar flaps have multiple perforators. So how do you select this perforator is the best and it can make the flap a success?
Yeah, position of the central region, the medial plantar region has most flaccid skin. Tension is low tension area for primary closure is the best choice. And also if you use palmar finger, you should design zigzag, multiple triangle. Oh, this is a very nice. So no need to do the Z-plasty, secondary Z-plasty. So primary star-like designs very important. Also, donor defect could be closed with zigzag closure to prevent contracture. Also, if you take a little big flap, free flap coverage is a very, very important. Yeah, prevent split thickness, skin graft, or flu sickness, because post-operative plantar nerve contraction occurs, constriction. So patients complain the very severe plantar pain. So flap coverage is very, very important. If you have another team or another professional microsurgeon, so simultaneous double flap transfer, domino transfer is a very, very, also is a
Professor,
very important point. Okay.
Professor Koshima, when you take this free flap, medial
Yeah.
plantar, you always take the superficial vein also?
Oh, yes. Yeah. Superficial vein is the best. Yeah, comitant
Yes.
vein is probably sometimes show very small. Comitant vein is 0.1 or 2. Sometimes occlusion may occur. So always
For a
choose
pedicle,
the,
it's fine. For a pedicle, it's fine. But for a free flap, we say superficial vein, yes.
Yeah, if possible, we should preserve the main trunk medial plantar vessel.
Thank you, sir. I think if there is no more questions, we should move towards the conclusion of our session. It was amazing experience today of learning and teaching. We learned a lot about multiple microsurgical reflaps around the limb. actually, and then we studied about the liposuction and lymphedema. So I would like Sachin to conclude the session with his final remarks.
Yeah, can you hear me?
Yes, loud and
Thank
clear.
you very much, Mansoor, for good moderation. And thank you once again, Dr. Yang. I'm sure this liposuction with LVA would be a revolution in future for cases where lymphedema 3, stage 3 and above cases will be very important. And with always Professor Koshima, anything we ask, he has already done it 40 years back. So I really wonder when I can do such small perforator based medial plantar flap, and I might try for one of the finger defects where I can put skin graft, but I would try to do this small thin medial plantar flap. Thank you once again, Koshima Sensei, and thanks to all the participants today and for a very good interaction. And we see you in the next webinar, which is, I think,